talk a little bit more about it. And so patient comfort is greatly improved when we do this under anesthesia. And so we'll talk a little bit about what brachytherapy is, when it's recommended, why we do it, and which cancers we kind of typically do it for, and then kind of just walk through a patient from diagnosis to the end of their treatment and kind of how this area will fit into that treatment paradigm. So, like she said, I'm Dr. Cantrell. I'm one of the new radiation oncologists. I'm originally from East Tennessee, but did my training in Oklahoma. So it's good to be back in the mountains and hear some familiar accents. So brachytherapy basically just means short therapy. Brachy means short. So like a pug or a Boston Terrier, those are brachycephalic dogs because they have short heads or short noses. And so when we say brachytherapy, that's all we mean is short therapy. So we're using a radioactive isotope to deliver radiation to short distances. And so that requires us to put the radiation either in the patient or like using an applicator or with needles into their tissue. We will divide brachytherapy generally into two broad terms, high dose rate and low dose rate. Low dose rate you might think of like prostate seed implants where you're putting a lot of little seeds into the prostate. They stay forever and they deliver dose over a kind of, a 2-month period. But they need to stay in place for a long time to deliver the dose to get rid of that tumor. High dose rate uses a much higher dose of radiation. So it takes minutes to deliver, and the radiation does not stay with the patient or travel with them. But it requires using applicators or devices or needles to implant or insert into the patient to allow us to get that radiation close enough to deliver that short therapy. In general, I have some pictures here of what our high dose rate brachytherapy looks like. You're not going to see it on my phone, but it's basically a machine that's about as tall as this table, and the belly of the machine is a very thick lead-lined chamber that holds the radiation. The source of radiation is very small. It's only about this big. It's an isotope of iridium. It's very active, and it's surrounded by stainless steel and is welded to a wire. So in the top of that machine, there's a motor that just pushes that wire out, and we can have 10, 15 catheters that are attached to whatever device we decide to use that will allow that radiation to go out of that machine into the patient, and then it's withdrawn, and then there's no radiation in the patient. It's back safely within the machine, and then we're able to come in and take all the equipment out. So using the high dose rate brachytherapy really limits our exposure as healthcare workers. We're not physically handling sources. The patient isn't being transported throughout the hospital with radiation actually inside of them. And so most of the time, especially for gyne cancers, we're using this high dose rate brachytherapy. And that drastically will reduce our chances of exposure as healthcare workers. So we have high dose rate, low dose rate brachytherapy. We also will kind of divide the types of brachytherapy we do into how we're getting it to the patient. So for GYN cancers, we will have what's called intracavitary, where we're putting a device into a cavity, either the uterine canal, into the vaginal canal, or we'll have interstitial brachytherapy, where we're using needles to actually go through the perineum to get tumors that might be more lateralized into the perimetrium. Or there's a mixed where you have a device that's within the cavity as well as needles. And so we can do any of those three things, but what we most commonly do is called intracavitary. And so that's the Tandem and Ring, the Tandem and Ovoid that several of you have participated in. Here at UT, we typically will do anywhere from 40 to 80 of those procedures a year. So not a ton, but enough to need to keep our skills up and know how to treat these. It's an integral part for the definitive treatment of locally advanced cervical cancer. So when you have cervical cancer in its early stage or confined to the cervix itself, oftentimes that's treated solely with surgery. If it has advanced outside the cervix, gone to lymph nodes, we'll typically treat that with chemo and radiation together, and then we'll boost it with brachytherapy. And so the use of brachytherapy in the definitive management of cervical cancer improves local control as well as overall survival. So this is over just continuing to use our traditional type of radiation to do the boost. The brachytherapy boost really allows us to, because it's short therapy, to get the final dose of radiation right to the tumor and spare the rectum, the bladder, and the things that are nearby that are important. So let's see what we got here. So let's just chat through a typical patient kind of from start to finish, and then we'll spend some time at the very end with questions for you all to ask, and hopefully we can answer them to the best of my ability. Then I brought some show and tell. We can look at what one of these devices look like. Our Tandem and Ovoids are all either being cleaned or they're already sterilized. So this is one that we had out for another demonstration, and so it's a little bit different than what we normally use. So let's say we have like a 43-year-old female patient. She has vaginal bleeding. She has dyspareunia, pain with intercourse. She goes to her primary care doctor, and they do an exam. They see a friable, fungating cervical mass. They will then refer them typically to one of our gynocs here, so Dr. Kilgore, Dr. Boone, Dr. Kimball. And they do an exam. They'll do a biopsy. 95% or greater of these types of tumors of the cervix are related to squamous cell carcinoma and are mediated by the human papillomavirus. So they're HPV related. Public service announcement, there is a vaccine for that. I know some vaccines are controversial. This one can prevent cancer, so I'm on board with that. Then we won't have to do this anymore. So they'll get a biopsy, squamous cell carcinoma. Typically they'll then go have a PET scan or an MRI of the pelvis, and then plan for radiation. They'll get sent to see me. The gynoc will prescribe the chemotherapy. I'll define and plan the radiation for them. And they'll typically have 5 weeks of radiation, Monday through Friday, and that's done externally. So that's kind of the traditional radiation that everybody gets, aimed at the pelvis, the lymph nodes, and everything. And so they'll have Monday through Friday, 5 weeks of radiation with chemotherapy. And then towards the end of that, we'll get an MRI and evaluate the response. Sometimes these tumors go completely away, and we do a little bit lower dose of brachytherapy. Sometimes we still have a lot of tumor left over, and we have to get creative with how to get our final dose of radiation in there. So that is kind of determined on that MRI that they'll have. So, up from diagnosis to the time that we're ready to do brachytherapy is usually a couple months even. And so they've been through a lot by that time. They're usually tired, and they're ready to be done with everything. And so I think that's important to keep in mind as we also take care of them and deal with sometimes some challenging personalities that we see with these types of tumors. But once it's time to do brachytherapy, typically, that we like to, here at least, we like to do that in the OR. Right now, our current plan is to do the first one with the gynoc present as well. So it'll be myself in tandem with the gynecologic oncologist, just so that we both can get a good view under anesthesia. Because oftentimes it's hard to do an exam after they've had 5 weeks of radiation with them in the office. It's just uncomfortable, as you can imagine. So that first day when we go to the OR, typically each patient is going to be, and again, this is not the exact thing that we'll use, but it looks similar to a tandem ring once it's all put together. But typically we'll do an exam under anesthesia. We'll then put a Foley catheter in, because we will typically inflate the bladder when we do our treatment. So we want to be able to control the bladder filling so that less of the bladder gets radiation. You can imagine if the bladder is just a muscle balloon, so if it's empty, it sits right next to where we're doing all of our treatment. If we inflate it, we can push 75% of the walls of the bladder away from our radiation, so it gets less radiation. The posterior wall where the cervix and uterus is, and you have your rectum back here, it'll still get some radiation, but it'll be much less if we inflate the bladder. So that's why we put a Foley catheter in, as well as the fact that they're going to be pretty much captive on the bed for a few hours, and so they're not going to be getting up to use the restroom as well. We will then dilate the cervix, so we want to be able to get our tandem. This is what, when we say tandem, this is basically what we mean. I don't know why it's called tandem. I should have looked that up, but basically this is the device that goes through the cervical os and into the uterine cavity. So this would be the uterine canal here, and the cervix would be kind of right here. The cervix is basically a barrel-shaped organ. It changes when you get invaded with cancer, but it's, it could be this big, it could be this big. It just depends on the patient. So the tandem, after we've dilated the cervix, is placed through the cervical os into the uterine canal, and then typically we'll have a ring, and it'll look something like this. It will just go around the Tandem, and it's one piece. This is a different type of applicator that allows us to do some other extra things. But effectively, this is what a Tandem ring looks like after it's been put in. An ovoid looks very similar to this, except it's two square ovoids. We call them ovoids because they look like ovaries. And they sit down here as well, right at the cervix, to performs a very similar function to the ring. But this is what gets placed, and then typically this set does not have one, but typically we'll have a shield that goes in behind this to shield the rectum from the radiation as well. So all that gets placed in the OR with you all, and then we'll do a lot of vaginal packing. Once this is in place, you can imagine that if this is in place, this would be the front of the patient, this would be the back of the patient, okay? I have some pictures on here, but that's gonna be hard to see. So the bladder's kind of right here, the rectum is back here. So we have a rectal shield to help that, but part of the bladder wall will be kind of right here at our high dose area where the ring is. So a lot of our packing is designed to kind of create some distance as we, from the bladder to the actual device, as well as to hold this in place so this doesn't move. So we'll do our packing. After that is when they'll get transferred to the radiation bed. We'll bring our own bed over here because after they leave you all, they have to be with us for a few hours. So the transfer to the radiation bed is always fun, but once we do that, we want to do that very carefully because if this moves or gets out of line, then our treatment's not as effective. The packing should help prevent that, but every once in a while you get a patient who's a little unwieldy and hard to move around or has some excess body tissue. But once they're to the bed, we have an immobilization device that kind of lies under the patient, has an arm. Some of you have probably seen it. And that actually will attach, this is a different applicator, but that will attach somewhere along this device and hold it, basically fix it in place. Once that is attached and affixed, it's very important that we keep the head of the bed below 15 degrees. That's pretty much what you'll always hear Kim or myself harping on. And that's because once this is in there, any movement of the patient this is fixed. And so any movement of the patient will change the geometry of where the uterus and cervix is. And so you can have instances where this actually goes through the uterine wall or through any cervical tissue. The area that we're treating is weakened from radiation, is weakened from the tumor. And so that's kind of why we harp on that so much. And it gets even more complicated. Let's say if a patient's tumor is not just right at the cervix, but maybe it's out here and involving the parametrium, we can do a procedure where we use an instrument like this, but we'll actually use needles to get our radiation to different areas. And so these are inserted, usually with ultrasound guidance, to allow us more channels to spread our radiation around to cover the tumor better. And so with the needles in place, it becomes even more important to keep the patient flat because you can imagine if you have needles kind of coming out here to the side and the patient moves around and they get inserted more than they should be, you can injure the bowel, you can injure the bladder, as well as the uterus. So that's why we harp on that so much. After they kind of wake up from anesthesia, we feel like their pain is controlled, which can be difficult sometimes in these patients. Typically, you'll call Kim, and somebody in our office will come and get them and bring them over to the radiation oncology department, which is just across this road, but it's a very circuitous route to get there. And once they're there, they will have a CT scan, so we'll transfer them from our bed to the CT scanner. We'll do a CT scan, and every day they will get an individual plan. So we do this type of treatment about 4 to 5 times for every patient. So after they've had their 5 weeks of radiation, they have to come in here 5 times basically and have this done. And they'll get an individual CT every time and a plan that is custom to their geometry that day. And so after they do the CT scan, we get transferred back to our bed, and then they'll wait for about 45 minutes to an hour for myself and the physicist to actually go in and say, okay, this is what we want to hit with the radiation, this is what we don't want to hit with the radiation, and come up with a plan. Once the plan is ready and approved, the patient will be rolled into our brachytherapy vault, and it's really small. It's not much bigger than a bay here, maybe a little longer, but not any wider. So the bed gets rolled in, and that's where this machine is. And so this is in place into the patient. She's laying flat, and we have a machine here, and we'll have a catheter that will run, and we attach a catheter to each of these devices. that allows our radiation to go in through each of these and deliver dose anywhere along this line, anywhere along this ring, and if we have any needles, into any of the needles that we have. Each treatment is probably only 5 minutes, maybe 10 minutes if our source is old. We have to, that source has a half-life every 74 days, and so we change our source out, every couple months to keep it active. But anywhere from 5 to 10 minutes, and then we're done. But there's all this, pomp and circumstance of getting it in place, making sure they're comfortable, getting a plan done, and then getting it delivered. And so the patient typically from, time out at 7:30 in the morning to discharge in our facility is probably 7:30 to about noon. So they're with us that whole day and discharge from our facility across the way. And so after the treatment's done, we all leave the room, we close the door. It's a big, heavy, concrete shielded door. And we step out, we deliver our treatment. We can watch the patient via like closed circuit television, so we can see them and hear them. And they can talk to us. And then after it's done, we go in, we take out all the packing, we take out all the needles, take out all the Tandem and Ovoids, and then take the Foley out. If they have an IV, take that out, and then discharge them from our clinic. And then we do it again a couple days later. So that's kind of a general overview of what we're doing, hopefully why you understand why we're doing it, and we got plenty of time for questions or for bathroom breaks or whatever.
So do you leave the catheter, leave their bladder full for
Not
the
the whole
majority
time.
of the time? Okay.
No.
So you just do it here and then whenever you're back over there?
Correct. So actually, even while they're here, it doesn't have to be full. So we will inflate the bladder with a specified amount of fluid at the time of CT, so that when we do our planning, we know where the bladder is, and then we will let it empty while we're doing our plan, creating our plan, and then when it's time to treat, right before we're about to treat, we inflate it to that specified amount. So it's only inflated to that specified amount, probably 10 minutes for the CT and probably 15 minutes for the treatment. The rest of the time, the bowl is just left open and they can drain. Good question.
And then in recovery, these patients are, normally our fluff is giving them something to drink and something to eat. Is that something that we should be not holding, but trying to limit how much they're eating and drinking?
I mean, technically, I guess it doesn't really matter. They've got a Foley in place, and we don't want to give them anything that's going to move their bowels because they're not going to be able to get up. So in general, I wouldn't want them having a meal because they're only going to be here for 4 to 5 hours, and so they can eat after we're done. But if drinking is not really an issue as long as from a post anesthesia perspective, they're alert and aware enough to be able to do it.
The one lady did here, you wanted her to have a snack and a pain pill though, so snack is okay.
Snack is okay, especially if we're giving medicines, and yeah, that was a particularly challenging patient, as you all probably know, so pain control was very difficult with her. Usually, with the medicine they get either during or the procedure or in the PACU, they do very well. We're able to take out these instruments just fine, and then a little Tylenol or some ibuprofen the night of is all they need. Occasionally you'll have, and usually it's the younger patients, but you'll have patients who are, either they've chronically been on opiates or they have a higher threshold, or lower threshold for pain, higher threshold for opiates, and those can become difficult patients.
Another question, you talked about the needles potentially like a bowel or something. How often does that happen?
Very, very rarely.
Okay.
We're very, very careful. But that's kind of why we make sure we're not moving them around too much when we move them from bed to bed, or when making sure that they lay flat, that doesn't happen. Usually, if we do more than a few needles, we will actually go to the main OR, and they will remain inpatient. So we don't take them in and out. They get put in once, and then they get all of their treatment over about 3 days. So those are patients that wouldn't be coming to day surgery. But it is potential that we would do a few needles for kind of smaller tumors in certain cases, and that could be done over here. So I wanted to bring it and show you. But in general, we would do that under ultrasound guidance when we do needles, and so we'll know if we're near those luminal structures to puncture them. Additionally, we will typically do a pre-plan on the MRI to know, okay, if we use these needles, we only want to advance them 3 centimeters on this side or 2.5 centimeters on this side to kind of limit that that chance. But oftentimes we're not going to know until we get over and we do the CT, and that's when we'll be able to see everything. Because even with ultrasound and even with the best planning, sometimes it does happen. In general, you just take the needles out, you give them antibiotics, the bowel, and every bladder, anything you puncture fills up very quickly, and it's not a great deal, but it ruins the treatment for that day. So everything has to be removed. We can't do the treatment that day, and so then they got to come back and start all over again.
For people who have like chronic back pain, or have you noticed there's a problem for people to lay flat for that long? Can we do something with their legs or pillow under
So
knees,
we
or-
can, put something low under the legs. The position of the pelvis changes quite a bit though with the legs moving as well. So just as if moving the torso upwards, if you move the legs up, the pelvis also tilts as well. And so with a fixed geometry, you can also run the risk of if you have their legs above their head, of changing the pelvis. And but any kind of a pillow, a towel, under the leg to help, that's totally normal, and we will often do that when we're doing other procedures that are completely outpatient, just to kind of get the patient in a comfortable position.
Do you still put them on the adduction pillow? We came out with adduction pillow.
So Dr. Dill used that very, very frequently. I haven't been using that as much, but there are certainly instances where that might be beneficial.
And they're still on the sliding board and
Yeah, so we'll bring it, the bed will come over with the sliding board, the immobilization board that attaches to the device, a pad to kind of, to help, provide a little extra comfort, but it's not comfortable, and probably a sheet to help us kind of further maneuver them as well. So that'll all be there. And then another point is, I always try to make a habit of it, but I don't always, is when we leave the OR, we only use, this comes with 1,800 pieces, and we only use like 5 of them. And so I always try to make sure that we get our tray with the patient, and then Kim will be responsible for getting it to sterilization and everything, so that we keep track of all of our trays. And so sometimes I'll walk out and forget, but we can remember that when the patient's done, this gets wrapped up and travels with the patient back to us.
Is this under MAC or is it general?
So I've seen it done both ways. It can be done both ways. I think here we've typically done general anesthesia though. But there are places around that will just do kind of conscious sedation even and do these. If I were the patient, I would not want it performed that way. So we don't generally do that. But there are some people that do these, even with needles, outpatient, but with either like a local kind of like anesthesia block to help, kind of similar to an epidural or a nerve block, or with conscious sedation. But yeah, it's all over the board. I think most people will go to the OR, or they have a dedicated brachytherapy suite within their radiation oncology department that anesthesia will travel to and perform the anesthesia. But I would say, for the most part, these are done with anesthesia across the country.
In pre-op, are there 2 consents they're supposed to consign, one for each?
So yes, there'll only be one there'll only be one that gets signed for the actual procedure itself, that gets done daily. And that's an order, typically on that first one that we do in conjunction with Gynonc, usually it has the Gynonc name on that, not mine, and then the subsequent ones will have my name. We also have a form for the brachytherapy in general that they will have signed in our department that's within our system, but that's not anything that we have to worry about over here. But that's a good question, because I think we did run into an issue with that at least once.
I couldn't remember, but for various reasons, sometimes the patients had to cancel some treatment, and I couldn't remember were they able to make up for it.
Yes. So if we have to miss one, we are able to make it up. In general, once we get started with the first treatment of their external beam radiation, we're kind of on the clock. And so a missed one does throw us off. It is a little bit less effective at controlling their tumor. But there have been studies in even late or delayed or prolonged brachytherapy is better than no brachytherapy. So the outcomes are still better if we're able to do the brachytherapy. but it's better if we can get it all done in close proximity to their external beam. The nature of some of the patients that we deal with in this population is some of them are unreliable and due to social circumstances and things of that nature. So that can be difficult sometimes. Sometimes their external beam gets prolonged so much that by the time we do brachytherapy, we're already outside of that window. But we still offer it because it does provide a better local control as far as the tumor goes. But we'll typically, then just have to recoordinate, reschedule, and it does become a hassle.
What happens with the patient's families? Like, do they follow them over to
Yeah.
the cross?
Yeah, so here they'll wait out there, and then once Kim comes to get them, they'll typically follow us over to radiation, then they'll be in our waiting room. And actually, other than when they're in the CT, when they're in the OR, when they're in the PACU, or when they're actually getting treated, the family member can be bedside. They're with them the whole way, and we usually tell them, bring some earphones, bring a book, bring something to occupy your time. Because once you tell somebody, okay, you can't get up, then that's the first thing they want to do. And so it is difficult to have to lay there for a couple hours and know that you can't get up.
Do you guys give them any kind of sedative or anything like that?
So-
Like a Valium or?
We will sometimes do that, or we'll prescribe it to them beforehand and have them bring it. The way that our clinic is, it's entirely outpatient, so we don't have any way to dispense medications. So that has to be done beforehand, and they'll bring it to clinic and they can take it on their own accord. Usually we try to get them, tuned up over here with anesthesia in the PACU before they get over there. Oftentimes it's not necessary, but occasionally it is, and that will either prescribe them some pain medicine or a benzo or something to take kind of a few hours after the procedure, right before the other. We start, kind of get going over there just to allow them to get through the procedure.
And we're still like, if they're, they've had the procedure placed in the OR and then they're in PACU, we're still treating their pain with our protocol. Like, if they need IV Dilaudid, we're giving them IV
Yep,
Dilaudid.
and I prefer that.
Okay.
I want it controlled, right? Because if it's not controlled, then they're going to move around more. So they move their legs more, they shift their body more. With that being fixed in place, that creates more pain for them. They don't know it, but they're going to be more sore later on. And it also, you kind of run the risk, if they're not controlled and they're not fully conscious yet, and they decide to just get up, then you kind of run the risk of having, those things like punctures and things like that. Yeah. So, yeah, so I am all for the good control of their pain while they're over here. And the better it's controlled when they leave here, the better it's, going to be for them as they wait on us to do all of our stuff across the street. I think it's 7 on the dot. So,
Yes.
do you have any last minute things for us?
That tray, does it go through the washer or does it immediately come to with the patient?
This will be sterilized, and I will usually bring it. I will usually bring the tray, or Kim will bring it. And so I will bring this to the procedure. After the procedure's done, the remainder of parts will just, the lid will get put on. We usually put it in a biohazard bag, and it will travel with the patient under the bed to us. That way, when we take out everything, it gets unified with its friends and then sent to sterile processing.
And so whenever we discharge patients, we're just gonna discharge like normal, have them sign, their family sign the discharge paperwork.
We don't do discharge.
Thank you. And then, so do we need to come with them over
No.
to your office?
Nope.
Okay.
Yeah.
I discharge them.
Yeah. Kim will
Unless
discharge
they're in
them.
our
Okay.
facility.
Yeah. So yeah, Kim is responsible for making sure Foley's and IVDs and everything are,
There we go.
all foreign objects are removed and they're discharged appropriately.
We need a diagnostic scope setup available in case perforation happens. Do we have something ready in case?
I don't think that's necessary. No, it would be very, very, very unlikely unless we're actually putting a lot of needles in. And if we typically do that, we'll have gynonc present, and then we'll have the ability to open them up if we need to. When in doing intracavitary brachytherapy, that's not really a risk. It's usually a risk after we're done in the OR. And like I said, typically that's managed by just removing the applicators, giving them some antibiotics, and letting things heal up. If not, right? If it's more severe than that, then that's why our friendly gynocs are standing by, and we get them over to the OR with them. But that's a very, very, very rare scenario, especially with just tandem and rings and tandem and ovoids. In fact, I wouldn't worry about it in that scenario. When you're doing needles and things like that, it does become a little trickier with artery bleeding and things like that. But typically that's done, all of that stuff, the bleeding and the things like that, that happens over in our department, not over here. And so that's when, if that happens, then we just get on the phone and we try to get them back to an OR with gynoc. Good question. All right, have a good day.
Thank you.
Thank y'all.